Thought I'd start tonight just talking about an old friend of mine named Sam. Back in 1992, if you look at the photo up here in the right-hand corner, you can see that I was quite a bit younger than I am now. And I had a lovely golden retriever mix named Sam. And Sam was 4 years old, and he had a sarcoma on his side. I was a second-year surgery resident, and I didn't know very much about cancer surgery. And I'm just trying to illustrate what can happen when you don't do the right thing with respect to cancer in animals. So Sam had this sarcoma, and I removed it, kind of scraped it off the abdominal wall, and within about a year it was back. And sadly, at that time, I didn't know how I was supposed to manage these things, and Sam was put to sleep. And I know for a fact that if Sam walked in the door today to my clinic, I would manage him completely differently, and there's a very high chance that I could cure him. And so that was just a real sad realization to me that the way that you treat cancer in animals can really affect the outcome. I started off, when I finished vet school at University of Florida, I went to the Animal Medical Center in New York City for my internship. And I'm not sure if you guys have heard of this place, but it's this non-for-profit hospital, 9 stories high in the Upper East Side. We had 95 doctors on staff, and we saw about 67,000 cases a year, and on average about 250 case presentations a day. So it was just an amazing kind of trial by fire in learning about treating animals with all kinds of different diseases. But even then, I didn't learn very much about how to treat cancer properly in animals. So I did my surgical residency at Virginia, Maryland Regional College of Veterinary Medicine, which is a beautiful setting in the Blue Ridge Mountains in southwestern Virginia. And that's where I met Sam, and also where Sam unfortunately passed away. After my residency, I went on to Auburn University and did a cardiac surgery fellowship for a year. And then my wife got a job as a faculty member at Colorado State University, and I got there without a job, and I was just planning on studying for my surgical boards, and came upon this group of people. And Colorado State University at that time, and probably continues to be, was the largest center in the world for treating cancer in animals. And it was headed and started by this guy, Dr. Steve Withrow. And he was just the most amazing, inspiring, and inspirational guy you could ever meet. Kind of a cowboy from Minnesota, but he was the one who really opened my eyes on treating cancer in animals, and it really forever changed my life. And so I've spent the last 15 years that I've been in Australia teaching primary care vets how to properly treat cancer in animals. And it's interesting that my referral caseload has dropped significantly over the years, and it's not because there's less cancer in animals, it's because primary care vets are managing them really, really well on their own. And so for a lot of cases, the majority of cancer cases that present to primary care vets, a lot of them with appropriate diagnostics and that kind of thing can manage them really well. So my name is Charles Kuntz. I'm one of the surgeons at Southpaws, and I'm going to talk to you tonight about lumps and bumps and when to worry about masses on my pet. And I thought that this was timely because with isolation, with COVID-19, people are spending a lot more time at home and probably noticing little lumps and bumps and things on their pets, and would like to know how to manage them. Most important thing to remember is that your primary care vet is the first stop when you're trying to identify and treat a lump or a bump or a mass or something on your dog, because they have so much experience and so much knowledge, and so you always start with them, and then going from that point forward, they can help you make a diagnosis and recommend a treatment plan. So the first thing I'll talk about is what is a mass. A mass is an abnormal collection of cells, and it doesn't tell you whether it's malignant or benign. It's just an abnormal collection of cells. So what does malignant or benign mean anyway? And we hear about it a lot in the news and in the newspaper, and from your doctor, and people talking about things that happen to their pets and to their family members. And we tend to think of malignant and benign as being a black or white scenario, but the fact is that it's actually shades of gray. And we have some tumors that would technically be considered malignant, but are actually fairly well behaved, and we have some that are considered malignant that are really, really nasty. And so just hearing or finding out whether they're malignant or benign really doesn't give you that much information about how it's going to behave. So what's the definition of malignant? Malignant, the dictionary definition is something that's evil in nature or effect or malevolent. And that's how malignant cancer tends to behave. And generally, we think of a malignant cancer as being capable of uncontrolled spread throughout the body, local recurrence, and potential for, to cause death in either a human or in a pet. That's generally what we think about when we think about malignant. So, first thing you want to do when you are treating cancer in animals is to know your enemy. And you can't effectively treat cancer without knowing what you're dealing with. And so the most common, and I'm sorry, I'm just looking on my phone here to see if we have any, let's see. And unfortunately, the live chat has been turned off because I said that this lecture was appropriate for kids. So what I'll do is afterward I'll change that, and you guys can also email me directly at my email address, which is ckunz1@mac.com. Anyway, so what they're doing on this slide is that they're taking a sample of the tumor cells and they're putting them out on a slide, and then they're going to look at it under a microscope and see what we're dealing with. And so that's the first thing, is that you have to know your enemy, find out what you're treating. The next level of making a diagnosis is doing a biopsy. So a fine needle aspirate is the first thing, and that can often be done with the patient awake. You put a needle into the tumor, put it on a slide and have a look at it, and then the next level would be to do a biopsy, and often we use a punch, which is kind of like an apple core. Take a sample of the tissue and submit it for analysis. So. And that gives you a lot more information because it's a larger piece of tissue, and you can make more inferences about malignant versus benign, how invasive it is, how likely it is to spread. So the next thing we do after we know our enemy is we do staging. And staging basically is trying to determine the extent of the tumor in the primary tumor site, so around where you can feel the lump, and also systemically. So you might include doing chest x-rays to look for multiple masses throughout the lungs, trying to determine, is it highly invasive or has it spread to other places? And so staging might include doing an aspirate of the mass. It might include doing an aspirate of the regional lymph nodes, taking chest x-rays. Sometimes we do even more, like doing ultrasounds and CT scans and stuff like that. But we're trying to determine where it is, has it spread, how invasive is it? And often, what guides our staging is reading up on the tumor and finding out, okay, a sarcoma is more likely to spread to the lungs, whereas a mast cell tumor is more likely to spread to the, to the lymph nodes, that kind of thing. So that's the next thing that we're going to do. And lymph node aspirate might include any one of the regional lymph nodes. And for example, if you had a tumor that was up on the face, up here, then we would go to the lymph node that's closest by, which would be the mandibular lymph node. If it was on the extremity down here in the leg, you would do the axillary or the prescapular lymph nodes. And so your lymph node assessment is going to be determined by the location of the tumor. And then when it comes down to treatment options, you have several different treatment options available for each type of cancer and where it is and that kind of thing. And so the least aggressive thing would be called conservative management. And then you can consider things like surgery, chemotherapy, radiation therapy. And I'll talk to you a little bit about those in just a second as well. So what happens if you don't treat a cancer in an animal? So you always want to consider what the lifespan of the patient is if it never had this cancer. And if it's an old dog that's got all kinds of other problems and has kidney failure and liver failure and all kinds of, arthritis and that kind of thing, you might consider not treating. Whereas if it was a younger dog that had no other health problems, you'd be more likely to treat, because the cancer itself is more likely to be the cause of that patient's demise. So, but if you had a young dog that was a year old or 2 years old, but it was in significant kidney failure or something like that, you might not treat it. And so you want to weigh back and forth how likely the cancer is to result in the demise of the pet versus how long other conditions that the pet has are going to result in its demise. And so it's always kind of a balance between the condition that the pet is in without the cancer and then the effects on lifespan of the cancer itself. And so if it's an old dog but it's healthy, you might go ahead and treat it, whereas if it's an old dog that is unhealthy or close to end of life, you might think about not treating it. So, and I'm really sorry that we can't do a live chat. Normally I can, but I didn't realize that if I made this available to children that that means that the live chat wouldn't be available, but I guess that makes sense. But you can certainly send me messages either at the end of this video. You can post questions afterward, or you can email me directly. So going forward, what happens if you do treat it? Well, the negatives to treating would be expense and potential suffering of the patient. And so suffering in terms of post-operative pain. And note that we're getting really, really good at controlling pains in animals. So when I went through vet school and when I was a resident, if we gave them a shot of an analgesic, a low-grade analgesic before we went home for the night, we'd pat ourselves on the back and think what a great job we're doing. Well, now we're so aggressive with pain relief, and vets in general are so proactive about pain relief that most patients can recover from surgery without any significant pain at all. And we have things like narcotic patches and codeine that we can give orally, and we can do non-steroidal anti-inflammatory drugs like meloxicam or something like that. And so we're very, very good at controlling pain in pets now. And hopefully by treating, we are extending the survival. And so again, we always have to balance, are we doing more for the pet by doing surgery or by not doing surgery? And in general, particularly with malignant cancers, treating them is going to result in a better survival than not treating them. So our treatment options for the primary tumor would be surgery or radiation therapy, and for secondary spread is generally chemotherapy. So that's something that can be confusing to people, but it's a very important distinction, is that surgery and radiation therapy are generally for the primary tumor. Chemotherapy is generally to prevent secondary spread. And that's not an absolute hard and fast rule, but in general, those are the things that apply. So with surgery, we want to cut with the intent to cure. That means that we're going to take very wide margins. And if you look at this patient here, this dog had a mast cell tumor on his knee, and then we got 3 centimeter margins all the way around the tumor. And the idea is that we're trying to prevent little tentacles from the tumor from getting past us and leaving cancer cells behind. And so unless the cancer is totally benign, leaving any cancer behind is going to result in recurrence of the tumor. Recurrence meaning that the cancer comes back in the same place. And so again, this one, the tumor was sitting here, and we were worried about microscopic extensions going out in all directions, and so we did a very, very wide excision. And so when we go in with the intent to cure these patients, we have to cut very aggressively unless it's a totally benign tumor. And once we remove the tumor, we're going to want to check our surgical margins. And what that means is that we're looking at the edge of the cancer here, and we want a margin of normal tissue between the cancer cells and the edge of the incision. And so that's a nice clean margin there on the left, and on the right, we can see an extension of the tumor going out to the edge of the margin, which means that that's almost certainly going to come back. And so margins, whether they're positive or negative, the completeness of surgical margins is highly predictive for local recurrence. If we get incomplete margins, with almost all tumors, local recurrence is more likely. So if the pathologist, so I'll come back a slide, if the pathologist looks at the biopsy sample and sees that there's a tentacle extending through the surgical margin in most cancer types, it's likely to come back. And the most reliable way to prevent local recurrence, if you have dirty margins, is to repeat surgery. And so here we've got a surgical incision from a previous surgical scar here, and we're coming around and taking a huge margin around the whole thing in order to control or get a hold of any tentacles that were left behind. Radiation therapy is also effective. So if instead of surgery, removing all this, say surgery wasn't possible or would require an amputation or something like that, radiation therapy can be effective where we go in and treat this whole area. And radiation therapy usually involves multiple general anesthetic episodes, between 15 and 20, often performed every day for 3 or 4 weeks, and it is quite effective. Chemotherapy may be effective with some types of sarcoma in preventing local recurrence, but generally we're talking about either repeated surgery or radiation therapy. Radiation therapy is of limited availability in Australia. We have an orthovoltage machine at our practice in Melbourne. That means, so it's very old technology. The technology is probably about 70 or 80 years old. Our machine is new, and it is very effective for certain types of cancer. But a linear accelerator, which is what's shown here in this image, is appropriate for deeper tumors and brain tumors and things like that. And in order to get a linear accelerator treatment for your pet, you'd have to go to Brisbane or Sydney. They have lots of these at human hospitals all over Melbourne. I would say there are probably 20 of them, but most of them don't allow pets to be treated in those centers. And so, again, orthovoltage is fine for a lot of tumor types, but if you have deeper things or tumors in the brain where you have vital organs that are close by and you need to protect them, then the linear accelerator is the way to go. Now, chemotherapy, the success depends on the tumor type and also patient-specific factors. So generally, dogs and cats go through chemotherapy. About 80% of them go through with no significant side effects. If they do have side effects, they're going to have malaise, some of them will have nausea and vomiting. Some can have issues with kidney disease, with heart disease or decrease in cardiac function, that kind of thing. But generally, like I said, 80% go through with no significant side effects, and another probably 15% go through with mild to moderate side effects that can be managed by altering the dose of the chemotherapy. Remember that chemotherapy is primarily to prevent secondary spread of tumors, not for controlling the primary tumor. So let's start with a few different types of lumps, and these are things that you're going to commonly see on your pets. And so the first category of tumors that I'm going to talk to you about would be skin or subcutaneous tumors. And with skin and subcutaneous tumors, we're talking about lumps that are underneath the skin on the trunk or on the abdomen or the chest or on the extremities like the arms and legs. All right, the most common ones that we see are mast cell tumors, soft tissue sarcomas, and lipomas, and they can all look the same. That's the problem. And so if you look at a lump on a dog, there are some, or on a cat, there are some parameters or differences in appearance that can kind of direct you in one direction or the other, but really you can't tell for sure. And so mast cell tumors can be very unpredictable in their behavior. Soft tissue sarcomas tend to be more predictable, and lipomas, which are just fatty tumors, almost every dog that's middle-aged or older is going to have a couple of these things. You may be able to differentiate these three using a needle aspirate, so that's where we put a needle into the tumor and look at it under a microscope. You certainly can't tell how malignant or benign the tumor is based on an aspirate. You may be able to, again, differentiate whether it's a lipoma, a sarcoma, or a mast cell tumor, but you wouldn't be able to tell the grade. And the grade is what's going to be predictive of how they're going to behave. All right, so mast cell tumors can be pink or with a pink central area. They can be either soft, they can be ulcerated, and sometimes they'll vary in size from one day to the next. And if somebody comes in and tells me that their dog has a tumor that's fluctuating in size from one day to the next, I'm going to be concerned that that is a mast cell tumor. Incidentally, what I've just decided that I'm going to do is that when I finish this lecture, I'm going to start a new stream straight away that I'll be able to answer questions for you. And so stick around. After this live stream is finished, I'll start a brand new one straight away that you'll be able to ask live questions on, and then I'll stay and continue with the stream until we're finished asking questions. So please stick around and ask your questions during the next stream. So mast cell tumors are variable with respect to rate of metastasis, and metastasis means secondary spread. And they tend to spread to the lymph nodes, liver, and spleen. But the rate of metastasis is very dependent on the grade of the tumor. They're usually graded 1, 2, and 3. Grade 1 tumors spread in about 5% of cases. Grade 2s are about 15% of cases. Grade 3s are about 85 to 100% of cases. You can diagnose a mast cell tumor on an aspirate. They're very typical in appearance on a fine needle aspirate, but that's not going to give you grade. In order to get the grade, you have to do a biopsy. And then staging is going to be through aspirating the lymph node, the spleen, and maybe the liver, and to determine whether it spread secondarily to any of those organs. Again, the behavior is grade dependent, and the treatment for these generally is surgery. If you do get a dirty margin, then you can do radiation therapy or a repeated surgery to get rid of the residual tumor. And you want to do chemotherapy if it's a high-grade tumor. And chemotherapy has been shown to reduce secondary spread with high-grade tumors. The level of concern overall with mast cell tumors is kind of medium to high. And some of the nastiest tumors I've ever seen have been mast cell tumors. But then again, some of the most benign tumors I've seen are mast cell tumors as well. So they can be highly unpredictable. Bad signs with mast cell tumors would be ones that are high-grade, near the mouth, near the penis, on the scrotum, or near the vulva. Those are the ones that tend to behave more badly, but any one of them can be quite variable in how it's going to behave. So looking here, we can see this is the eye in a dog right here, and then we've got a mast cell tumor that's sitting right up over the eyelid on the forehead region. And this is a very typical appearance for a mast cell tumor. It's kind of red and borderline ulcerated. They can be quite shiny and have this kind of pinky red appearance to them. Okay, lipomas, on the other hand, are usually or almost always benign. They're usually soft and slow growing, and you can make a diagnosis on those on aspirate, but recognize that if you have a lipoma sitting here, you could potentially, in the center of it, have a mast cell tumor. And so you want to make sure that you do a good aspirate and get lots of samples throughout the tissue. We generally leave them alone and don't remove them unless they're affecting function, like affecting the ability to ambulate, or they're doubling in size in 30 days. Overall, the level of concern is low with these. But you don't want to just assume that something's a lipoma. It's probably a good idea to get it aspirated. And then the last one is soft tissue sarcoma. And they are kind of my favorite tumor, my pet tumor, because they're so predictable, and a good surgery can cure a lot of these guys. And so they can be slow, medium, or fast growing. The staging that we want to do with these would be chest x-rays and a biopsy. Chest x-rays would be to see if it spread secondarily, and then the biopsy is going to be to determine the grade of the tumor. Bad signs would be high-grade tumors and rapidly growing tumors, and tumors on the arms and legs generally are less likely to metastasize. So, these are kind of my favorite tumor. When I see one of these, I know that I can almost always cure them, at least of the primary tumor, and then the risk of secondary spread is relatively low, probably about 20% overall. If they occur on an extremity, meaning on an arm or a leg, the rate of secondary spread or metastasis is probably less than 5%. So I would say that the level of concern with these would be moderate. Okay, osteosarcoma. This is a common tumor that we see in large and giant breed dogs, an average of 8 years of age. And I spent a lot of my time when I was at Colorado State University doing research on these tumors. One of the reasons why we study it so much in dogs is because it acts as a great model for the same cancer in humans. And so in dogs it happens in kind of middle age or older dogs. In humans it tends to be teenage, large, or tall boys. Boys occur more frequently than girls, and it tends to occur in the ends of long bones. So this is the humerus sitting right here. That's the shoulder joint up there, and then we can see that the bone is all moth-eaten away. And so because this was a model for human cancer, we got a lot of treatment done on animals that were done at a reduced cost. I'm not aware of a lot of clinical trials that are going on in Australia right now for osteosarcoma, but it certainly is worth having a look. Generally, the treatment is surgery with amputation. Generally, that's what we do because it occurs most often on the arms and legs, and then chemotherapy. And with the combination of treatments, we get an average survival time of about a year. Bad signs would be a large tumor, a tumor that occurs on the spine or on the upper jaw, so the maxilla or upper jaw, or the top of the humerus. Top of the humerus tends to have a higher metastatic rate and potentially a lower survival time. So I would say, given that with everything that we can do, chemotherapy, surgery, even radiation therapy, the average survival time is only about a year. I would give this tumor an average or a high level of concern on average. Okay, lymphoma. Lymphoma is a tumor that I don't treat very often because I'm a surgeon. These would generally be treated by the oncologist or the internal medicine specialist or the more advanced primary care vet practices. So there are certainly primary care vet practices that will treat lymphoma, but because there's a lot of chemotherapy and different cycles from different drugs and stuff like that, it tends to be the more advanced practices that do this. It can present as enlargement of multiple lymph nodes, or sometimes you don't see anything enlarged externally and it's just inside the abdomen or chest or something like that. But this image here shows an enlarged lymph node in a dog down here. All of these are enlarged. Generally with staging, we want to do an aspirate on it, and that's going to give us our diagnosis. If it doesn't give us our diagnosis, then we can go ahead and do a biopsy. We do an ultrasound to look at the liver and spleen and other organs to see if there's any secondary spread. And then we take chest x-rays to see if there's evidence of enlargement of lymph nodes in the chest cavity as well as spread to the lung tissue. And then we also do blood tests to look for elevation in lymphocytes and those types of things, just to try to get, and the whole idea behind staging is to get a better idea of where the cancer exists on the patient. The treatment is chemotherapy, except for very, very focal lymphoma, where sometimes you can do surgery or radiation therapy. Generally, it's a systemic disease, and so we're going to do chemotherapy, although it is unlikely to cure. Average survival time with chemotherapy, with the most aggressive treatment that we know how to give, is about 14 months. And bad signs that would be associated with a shorter survival time are going to be tumors affecting the gastrointestinal tract, dogs that are, or cats that are systemically unwell, so that present lethargic, vomiting, diarrhea, those types of things. Tumors that are high grade on biopsy, and then there's something called phenotyping, where you can look at specific genetic markers and appearance of the tumor under the microscope, and that's going to give you some more information. Because our average survival time, even with the most aggressive treatment that we know how to give, is only about 14 months, I'd say that this tumor has a level of concern which is high. And just to remember that I am going to be streaming again immediately after this live stream, where I'm going to do a conventional adults only live stream, which means that you'll be able to pose questions. So please save your questions until the end when I start the next live stream. If you haven't already done so, you can subscribe to our channel. If you like watching live surgery and things like that, I live stream probably 3 or 4 cases a week. We have 260 videos on our YouTube channel, and so where you are watching this right now, that is our YouTube channel, and you should be able to find a link to subscribe and also to watch the next video. So oral tumors in dogs, we see a lot of different types of oral tumors. Generally, the 5 most common that we see would be fibrosarcoma, osteosarcoma, melanoma, epilus, and squamous cell carcinoma. I did a big mandibulectomy where I took out the end of the jaw on a dog today for squamous cell carcinoma. The ones that are most concerning would be Melanoma, particularly large ones. Fibrosarcomas have a very high chance of local recurrence, and osteosarcomas have a moderate chance of secondary spread. And so epulous is probably the best one that you can have, and squamous cell carcinoma is probably second best. Bad signs would be large tumors, tumors causing facial deformity up in the skull and pushing the eyes in or out. Tumors that are black in color, which are more likely to be a melanoma. Enlargement of the lymph nodes up underneath the jaw. Diagnosis of melanoma, osteosarcoma, and fibrosarcoma on biopsy are going to be the worst ones. So the level of concern overall would be moderate to high with these guys, with melanomas, fibrosarcomas, and osteosarcomas being more concerning than epulous and squamous cell carcinoma. Oral tumors in cats generally are really bad, and most commonly we see squamous cell carcinoma in cats, and surgery is the only treatment that appears to be effective. And what you have to do is you actually have to remove the entire roof of the mouth on one side, including the teeth and the jaw and that kind of thing. Or if it's on a mandible, you might have to take out the whole end of the mandible or one whole side of the mandible. And my experience with these has not been that great, where even if you do a very aggressive surgery, they have a tendency to come back. And cats that have big oral tumor surgeries tend not to eat very readily after surgery, and so it can take days to weeks for these guys to start eating again. And so we're looking at probably tube feeding and that kind of thing. These tumors are very resistant to radiation therapy and chemotherapy. Surgery is really the only thing that you can try. And again, because the survival is limited and they have such a high recurrence rate, I would say that these tumors have a very high level of concern. In cats, particularly white cats, we get squamous cell carcinoma on the nose, nasal planum. Sometimes we get them on the lower eyelids up here. We do see them on the ears, up here, and on the forehead as well. It's almost always cats that get these, although occasionally we will see dogs that have them on the nasal planum. They're almost always squamous cell carcinomas, and they are solar induced in cats, and so it occurs most frequently in white cats. Treatment options include freezing, surgery, radiation therapy, electric chemotherapy, and the prognosis depends on the size and depth. If you have really superficial ones out here in the nasal planum, you can do cryotherapy, which is the liquid nitrogen freezing. But if they're more aggressive like this, surgery is more effective, and even surgery itself, often you leave cancer cells behind. Radiation therapy can be quite effective, but again, not for the really deep ones. Success rate's only about 60%. My go-to treatment now with nasal planum squamous cell carcinoma is a procedure called electric chemotherapy, which is where under a general anesthetic, you give a dose of intravenous chemotherapy, and then you shock the tumor with a high voltage. And what that does is it causes pores to open up in the cells, and then the chemotherapy rushes into the cancer cell and kills the cancer cell. My level of concerns with these is moderate, but if you have a really big one that's really deep, my level of concern would be quite high. And so my level of concern is dictated by the depth that the tumor penetrates. Another category of tumors is nail bed tumors, mostly in dogs. And the two tumors that we see in dogs in the nail bed would be melanoma and squamous cell carcinoma. And interestingly, melanomas of the skin in dogs actually are mostly fairly benign, whereas when they occur in the nail bed or in the mouth, they're quite malignant or aggressive. Squamous cell carcinomas on the skin of dogs also tends to be fairly benign, but when it's on the nail bed, it tends to be more aggressive. And I apologize for this gross picture here, but we've got a big nail bed tumor sitting here. And what these guys often present for is they'll go to the vet with a broken, bleeding nail that's swollen, and then people think, oh, it's just an infection, but it turns out that a lot of these are cancer. And so you want to, if you've got a nail, a toe that's swollen and bleeding, and the nail bed falls off spontaneously, it's worth getting a biopsy on that and finding out what it is. So that's one that you'd want to go to your primary care vet, get a biopsy, find out what it is, and then if it comes back melanoma or squamous cell carcinoma, we're going to want to do a toe amputation up to here. And function with the toe amputation is excellent in almost every patient. There is a moderate to high risk of secondary spread with these guys. Staging, we're going to want to do chest x-rays and then aspirate the lymph nodes of the affected leg. So if you have a nail bed tumor in a front leg, you're going to aspirate the prescapular lymph nodes in front of the shoulder and the ones that are in the armpit as well. Some people recommend chemotherapy with these guys, particularly if you had a high-grade melanoma. So because of the potential for secondary spread, I would say that the risk or the level of concern with these guys would be moderately high. So I'm going to give you a little action list. Look carefully at your pet for lumps and bumps, and I know that a lot of people are home and spending more time with them. And if there are any that you're concerned about, contact your primary care vet and get them worked up and get them staged appropriately and biopsied and that kind of thing, so that we know what we're dealing with, so that we can treat them early and aggressively. Now, there is a link in the description of this video to subscribe for future webinar content if you're interested in health-related issues in your pets. And so click on that link, and that means that the next time I do one of these webinars, I will send you an email beforehand. So I'm finished with my presentation now. I'm going to switch over to me primarily, and then I'm going to end this live stream, and then I'm going to start one up immediately afterwards, which is going to be children allowed. So just stay tuned for about 3 minutes, and I'll try to do the stream. Actually, I won't be able to do it through the same stream, and so just go to my YouTube channel, which is Southpaws Vet. So hang out at the YouTube channel, and then I will start live streaming a question and answer session in just a minute. And these photos here, let me just go back. These photos are all patients that we've treated that have had aggressive cancer, and the majority of them have actually done quite well and lived for an extended period of time. All right, so switching back to me, I'm going to end the live stream. Stay tuned, and I'm going to start one right away on the same channel, Southpaws Vet, and then you can ask your questions if you'd like.